Hi, everybody. It's Cynthia. Let me see if I can get to my shared screen. Okay. I am doing my final project on obsessive compulsive personality disorder. And oops, didn't want to get that big. Let's see if I can make that smaller. There we go. Okay. Here we go. Obsessive compulsive personality disorder. This is definitely different from OCD, which is an anxiety disorder. There are two questions that I want to address about OCPD. First of all, what is OCPD? Obsessive compulsive personality disorder. According to the Diagnostic Statistical Manual, the 5th edition, OCPD is a pervasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of being flexible or open or even efficient with your time, with whatever you're doing. What is the difference between OCPD and obsessive compulsive disorder, OCD? OCPD is a personality disorder, and it's got that strong prevalence of perfectionism. There's often feelings of anxiety, a fear of failure, or depression, which is brought on by not meeting personal expectations relating to perfectionism. OCD is characterized by the presence of obsessions or compulsions. Means reoccurring and persistent thoughts, urges or images that end up being intrusive and they're not wanted. Or it's repetitive behavior or mental acts that the individual feels they have to perform in response to that obsession. Let's go back to that for a second. So when you're looking at those two different things, they can overlap. And there are OCPD individuals that have some of the obsessions or compulsions, but OCD does not have the personality issues that OCPD has. So let's talk about the historical background of OCPD. The prevalence is that it's one of the most reoccurring and personality disorders. It's very frequent. The numbers are anywhere between 7.9 and 8.7% in your outpatient community samples. Your lifespan etiology is that there's indications that there's both genetic or environmental causes, but no single cause has been identified. There's evidence that personality disorders may lead to psychiatric disorders later in life. There's evidence that dimensional contributing factors like the environment or genetics that are identified in early or middle childhood and adolescence may assist in the identification of the development of a personality disorder like OCPD once they get into the adulthood area. Your diagnostic C, personality disorder based on anxiety, being anxious. The individual will be preoccupied with details and rules, lists, order, organization, and schedules to the point where the reason for the activity gets completely lost in the shuffle of lists and rules and making sure you get everything done in order. And there's perfectionism. This person's going to be a workaholic. They have no downtime. They have no idea what relaxation and downtime is. If they have downtime, they schedule it like it's a task. They're overly conscientious. They're inflexible regarding morals and ethics or values. They cannot or will not discard broken, useless, worthless objects regardless of the intrinsic value. So that's borderline hoarding. Which I didn't know before either. They cannot delegate tasks or work with others unless the tasks or the work is done to specific stipulations and performance standards. And the individual with the OCPD is the one who decides what those standards are going to be. They can be stingy by hoarding money in case of a future disaster. The person is very rigid or stubborn. Inflexibility probably is the one thing that really, really describes this individual. The common comorbidity is that it can be comorbid with generalized anxiety disorder, or social anxiety disorders and phobias, specific phobias, obsessive compulsive disorder. And there could be an association, like I said before, between the OCPD and depressive and bipolar disorders and eating disorders. Other characteristics can include ruminating about the past, just like, obsessing over what happened in the past, poor time management, time off that's scheduled to the minute, so it's really not time off, obsessively making lists, and if you lose the list, then you'll keep looking for the list instead of making another list from memory, obsessive cleaning, so I can eat off the floor, and it's never done right, and so I have to do it all because nobody else can do it as good as I can, or compulsive hoarding. The correlation to the 5-factor model of functional personality, the template that I used is called OCEAN. It goes openness, conscientiousness, extroversion, agreeableness, and neuroticism. What makes it easy to do this particular template is that you can see where they're low and where they're high, meaning that they have low, like for instance, openness versus closedness, low teachability, but the individual is highly constricted in their feelings. They're inflexible. They may even be dogmatic. And then you have conscientiousness versus disinhibition. They're going to be perfectionist. They're going to be fastidious. They're going to be I love this word, punctilious. It's like my favorite word right now. Definitely a workaholic. They're going to be doggedness. There's not, I mean, that again, there's this overwhelming sense of total inflexibility. Ruminative, they're going to just like fuss over the past or situations, or somebody said so-and-so, and I'm just ruminating over what they've done or said or haven't done or haven't said. Deliberation, they deliberate so much so that they can't meet a deadline. They can't meet a schedule or whatever, because they're sitting there not being able to make a decision. Extroversion versus introversion. They're going to be withdrawn. They're going to be detached and cold. And they have a total risk aversion. They're not going to take any risks because they got to be in control. They got to know what's going on. So they're not going to risk anything that they're not in control of. Agreeableness versus antagonism. They may have poor teamwork. They're not going to be agreeable. They're mistrusting. They're judgmental. They may be mistrusting in their head, not saying it out loud, and they may be judgmental in their head and not saying it out loud, but that interferes with a good teamwork, a good working relationship with coworkers, with family members, whatever. Neuroticism versus emotional stability. There is an undercurrent of constant worry, excessive worry, and living in fear, being very fearful, being restrained, not being just like open to new experiences. They're going to be restrained. And I think there's a lot of anger there because of the lack of control. And so they're hanging on like crazy, trying to control, but there's that underlying feeling of anger because they have no control over anything in all reality. The risk factors, you've got your developmental risks, which basically are speaking towards how OCPD develops. There is indication No specifics, but there's an indication that there's a genetic component to this, and more so the childhood environmental impact. So, for instance, if you have a situation where you have a child who has overbearing parents constantly being excoriated for not meeting standards, or in a very religious setting where there's almost an aspect of religious intolerance or religious abuse to that point. Men are twice at risk than women to have this. And then your diagnostic risks is that can be the comorbidity. There's the development of other disorders. And we talked about that a little bit ago, the depressive disorders, bipolar disorders, anxiety disorders, and then eating disorders. It can come to the point where the obsessive thoughts can interfere with usual activities, and there can be a paralysis where hospitalization and intervention hospital assessment may be needed. There we go. I did not know that there was suicidal ideation and the attempts or the completions. That was completely, I did not know. And I was pretty blown away by that part. Your diagnostic assessment tools, of course, there's the cross-cutters that are in the DSM-5, the various ones that are available. And the ones that I looked at that I liked the best were the structured clinical interview with the DSM-5, specifically developed for the personality disorders. It's using the DSM-5 diagnostic criteria. It's a semi-structured interview. There's 106 questions. It's an 8th grade reading level. It's on a Likert scale, a 1 to 5 Likert scale. And then the 5-factor obsessive compulsive inventory, again, is specific towards obsessive compulsive disorders, both of them actually. But this one uses the DSM-4 diagnostic criteria, which really isn't that different, other than they've taken out the Access 1 and Access 2. So it's also a semi-structured interview. It's 120 questions, and it can be, both of these can be used as a baseline measurement, and then again through the treatment phase to check to where to check how the goals are going, how the treatment goals are going, how the treatment process is working, and to see if in fact the person is improving, if the anxiety, if the issues that are some of the questions that are on these evaluations. Both of them are Likert scale type questions, which those tend to be my favorites. The case study that I developed is about a woman named Glenda. She's 56. She's an African-American woman. She's married. She's got 2 adult children out of the house, but 1 child is still at home. He's a high school student. Glenda is currently teaching cosmetology. This is her 4th position between 3 cosmetology schools, so she's bounced around. She is complaining of anxiety and frustration due to being passed over for a promotion. The supervisor says she has a lack of flexibility and that she's not teachable and is a poor team player. There are reports that she is dedicated to her job, has a high standard of performance for herself, but reports that her coworkers are sloppy and they don't care about the excellence in their work performance. She also reports that no one at work or at home support her work ethic. Glenda has been diagnosed with obsessive compulsive personality disorder. It's due to the meeting 7 of the 8 diagnostic criteria, which includes criterion 1, preoccupation with lists, details, and not meeting deadlines. Criterion 2, a perfectionist, not working well with coworkers. Criterion 3, a workaholic, neglecting family and friends. Criterion 4, inflexibility, uncompromising with standards and values. Criterion 5, inability to part with or discard broken, useless items. Criterion 6, demands that coworkers complete tasks following her structure. That again, there's that inflexibility, and will not delegate. Criterion 7. And Glenda doesn't really meet this criteria because she's not being stingy or miserly with her money at this point. And then criterion 8, rigid, stubborn, and uncompromising inflexibility. Again, there's that theme throughout the whole process of looking at this disorder, the inflexibility. When we're looking at general cultural and ethical considerations, the cultural considerations is that OCPD is diagnosed primarily in men. That can be very disconcerting to somebody, a female, who's been diagnosed with something that, it's the type A personality man thing. That can be pretty frightening. There's an estimated prevalence ranging from 2.1% to 7.9% of the general population. General population, we're talking around the world. So the presentation of symptoms in some cultures are seen as norms rather than problematic. For instance, in certain Asian cultures, these types of approach to work is prized as opposed to looking at it from a personality disorder, a compulsion. And in fact, they may not necessarily be, have the same issues, but the actual norms, as if I'm sitting with an Asian client and I'm looking at this and I'm talking to them about these things, these behaviors as being problematic, they may not necessarily agree with me. So I've got to be aware. My ethical considerations is that I need to be able to differentiate between OCD, which is an anxiety disorder, and OCPD, which is a personality disorder. And then I need to be aware that there are actual suicidal ideations. I did not know that. And the attempts and the completions, I did not know that. I was blown away by that. Specific cultural and ethical considerations relating to Glenda. I need to be aware of culture biases relating to the African American population and how those biases can impact personality disorder diagnoses. Statistics say that there are more African Americans that are diagnosed with psychological, psychiatric disorders than whites and Hispanics and Asians. And, where does that come from? I need to be aware of cultural norms relating to African American community and how they impact a personality disorder diagnosis. And then specific ethical considerations for Glenda. I need to examine my own personal biases relating to the African American population and how those biases may impact the trust building of a working relationship between Glenda and myself. I need to examine how client and counselor worldviews, assumptions, attitudes, values, beliefs, biases, social identities, social group statuses, and experiences with power and privilege and oppression do influence the counseling relationship. I need to really be aware of that. The treatment goals and plans that I came up with. Goal number 1, the treatment approach is cognitive restructuring. And Glenda needs to be actively engaged in a therapeutic process. And she needs to schedule and attend weekly sessions. They're 55 minutes within the month of August. Part of what I want her to do as far as behavioral changes, or starting to be aware of the behavioral and thought changes that she needs to implement, are being able to identify distressing cognitive behaviors and thoughts and the situations they occur in, and then make a list of those behaviors and thoughts. Second mini goal is to identify emotional responses, unpleasant moods, or problem behaviors that follow distress, follow the distressful thoughts, and then list those responses and moods and behaviors that correlate with the distressful thoughts. Identify more rational or desirable thoughts to replace her distressful thoughts. and list those rational, desirable thoughts. These 3 bullet points specifically are the cognitive restructuring. Your thought processes influence your behaviors. And so if she can identify certain thought processes, maladjusted thought processes that lead her to maladjusted behaviors, those are the things that we're looking at. That's her goals. And those are very visible. Those are measurable. I can measure those from week to week with her, from session to session with her, because she's got to make those lists, and she's a list maker. So that'll make her happy. And then the second goal is the treatment. The treatment approach is behavioral. Glenda needs to learn how to use relaxation techniques and diaphragmatic or deep breathing. These mitigate anxiety responses to trigger situations. And this isn't something that she's going to learn overnight. It's going to be something that she's going to have to practice and that will role play. And that's going to be an ongoing thing, being introduced probably in week 2, after the first week of just getting settled and figuring out what we're going to be doing and setting some goals. And she needs to be willing to set these goals. I mean, I've got these goals written down, but she needs to see the value and have her input and understand that these are her goals. She wants a better life. Glenda can't take homework with her anymore after working hours, and that will be implemented in week 2 and 3. Again, easing her into it. I don't want to overwhelm her. And she can't stay late after work, but that's week 1. That's week 1 through week 4 of the treatment. She cannot stay late after work. And then she needs to delegate a task to one of her co-teachers. We'll ease into that, maybe in week 3 or 4, to see if she can get to that point. Overall, there's things about this disorder that can be paralyzing. The rigidness, the inflexibility, the difficulty working with others when you've got such a rigid outlook on what's right and wrong. Some of this is for Glenda to realize that it's not that serious, and for her to use the relaxation techniques, which, and there's so many different ones, but learning how to literally force her body to unstress and unravel so that she's not all tightened up and wrapped up in a list, or in Susie Smuckatelli not doing what she's supposed to do because she didn't do it like Glenda did. And then the deep breathing, that just assists in the muscle relaxation process. I mean, it is so important. I think that Glenda has a good prognosis. She is actively seeking assistance. She wants to change. She wants a better life. She wants quality of life, and not to be so torn to shreds over things that she has very little control over, and then ruminating over the fact she's got no control over it. So thank you very much. Shoot me any questions if you have any questions, and I got my references there. So thanks, God. See you later. Bye.